these are the sorts of things I do look at. So I get my athletes, their feet are 1 foot, their foot, distance from the wall. And with kids, just bear in mind that if you want to be reliable in these tests, their feet are often still growing. So you actually need to measure that distance with a tape measure if you want to be truly reliable, because their foot may grow from 1 month to the next. And then what we do is with soft knees, we'll ask them to pelvic tilt. And I usually, the words I'll use are put my hand behind their back, between their back and the wall, and say, squash my hand. And then we'll see if they can do that, and do they stop breathing. At that point, I'll observe their breathing. Are they nose breathing or mouth breathing? Are their ribs coming upwards or downwards as they breathe in? And I'm not saying a whole lot at this point. I'm just observing. Keeping their lower back on the wall, can they then bring their arms overhead? So can they actually achieve full glenohumeral flexion and keep their head on the wall as well, and mimic what will happen during this service action? If they can do that, I'll often look at taking them into a W position on the wall and do little wall angels, where we start to slide between a W and a Y pattern, keeping the back of the arms in contact. If they can't do it, what's the different coping strategies? Do they flex their elbows? Or alternatively, is there a distance between their thumb and the wall? So it's really important that we globally think about what they may have done in terms of strategies, that if they are tight bringing those arms overhead, does that mean then that they're going into masses of rib flare or lumbar extension?